Good evening. I am Dr. Anil Pareek, Medical Director, ipca Labs. It's a great pleasure and privilege for me to welcome you on behalf of ipca Labs on this evening continuing medical education activity on hypertension management clinical outcomes with focus on chlorthalidone. Today we are having Professor B.K. Goel as chairperson for this particular meeting, and we are very, very grateful to Professor B.K. Goel. I would request Professor Goel to kindly come on the dais. Sir, kindly occupy the dais, please. I would request my colleague Johnny to felicitate Professor B.K. Goel and present a bouquet. Sir, kindly occupy the chair. Professor B.K. Goel does not need any introduction to all of us assembled here. He is not only known in Mumbai but all over India. He is a Padma Vibhushan, and he is an internationally acclaimed cardiologist and medical educationist. He is Honorary Director Medical Education and Research and Director Interventional Cardiology at the Bombay Hospital Institute of Medical Sciences, and former Director Professor of Cardiology at Sir J.J. Group of Hospitals and Grant Medical College. In fact, he has been instrumental in setting up a postgraduate medical institute at Bombay Hospital. He has also served as editor of JACC, that is Journal of American College of Cardiology of the Southeast Asia edition, and he is an inspiration for many of us, and particularly his association and well known from to our community in Rajasthan. I would like to add that, and now I would the lead speaker for today's CME activity is Professor Henry Black. I would request Professor Black to kindly occupy the chair. I request my colleague to present a bouquet in honor of Professor Black. Professor Black is Clinical Professor of Internal Medicine at the New York University. He has served as on the Executive Committee both 6th and 7th JNC, and he has served as President of the American Society of Hypertension from May 2008 to May 2010. In fact, he started his career with nephrology, and then subsequently he is deeply interested in hypertension. And in fact, many of you may be knowing he is the editor of the book Hypertension Primer of the American Heart Association, and which is a very, very popular book, continues to be popular. And Dr. Black also served on the US FDA Cardiorenal Advisory Committee from 2007 to 2011. He has published nearly 400 papers, chapters and reviews, and is an author and co-author of more than 220 abstracts. He is a very, very prolific researcher. He is on the editorial board of the Journal of American Society of Hypertension from July 2006 to present. And moreover, Professor Black is well known for his involvement in all the major landmark studies, and many of them have been sponsored by the National Institute of Health, like SHAPE, ALL-HEAD, and some other studies like Accomplish, Value, Help, Convince. And other thing I would like to add is many of us know him through his Medscape, where he regularly features on the video. So many of us know him through that. Now today we have a very, very eminent panel. I think most of the panel are such eminent people that there is no introduction required for them. And Dr. Ashok Kriplani, I would like to, Professor Ashok Kriplani, kindly occupy the dais. He is not only the foremost nephrologist of the city but of the country, and really needs no introduction for his contributions in the field of nephrology and hypertension. He is examiner for DM nephrology of Mumbai University since 1994, and total teaching experience over 30 years, and Consultant to Government of Mauritius, Department of Health, Consultant His Excellency Sheikh Sharjah and Royal Hospital of Sharjah, and he has been involved with API very, very regularly and Indian Society of Nephrology. And now I have the honor of welcoming Professor Siddharth Shah. Kindly occupy the dais, sir. I would request my colleague to present a bouquet in honor of Professor Siddharth Shah. Professor Siddharth Shah is again a very, very eminent figure, and we know him through his participation in API and his involvement in various education activities. He is editor-in-chief of API Textbook of Medicine, 8th edition, editor of JAPI, past president, Diabetic Association of India, API, Hypertension Society of India, convener, Indian Hypertension Guidelines, 1st and 2nd, chairman and convener of International Hypertension Conference, 1992, HDL Goa, Epicon, DIPSI, guest editor of special issues on IDDM, NIDDM, thyroid, alpha blockers, newer insulin, postprandial hyperglycemia, and needless to say that various scientific articles, over 175, and chapters in books and monograms. Now I'd welcome Dr. Ratna Parkhi. Professor Ratna Parkhi, kindly occupy the dais. A very leading cardiologist and very, very well known, particularly very popular in the suburbs of Andheri and Villeparle. He is consultant interventional cardiologist at Leelavati and Nanavati Hospital, and honorary associate professor of Department of Cardiology at Sion Hospital and Lokmanya Tilak Medical College, and profusely interested in academics and presentations and writing clinical papers, and member of the Cardiological Society of India. Now I would like to welcome Dr. Ajay Mahajan, associate professor, and deeply interested in continuing medical education activity, and whenever we request him, he is always there to help us in carrying out continuing medical education activity. He has done his residency at LTMG Medical College, and he was lecturer in cardiology at Grand Medical College, associate professor of cardiology. I think he has worked in, except Nair, I think he has worked in the 3 leading colleges at St. GS Medical College and KM, then consultant interventional cardiologist at Arneja Heart Institute, Nagpur, and presently associate professor of cardiology at Sion, then postgraduate teacher for DM, past secretary of CSI Mumbai chapter, joint secretary Indian College of Physicians. Now I would welcome Dr. Ashok Sirsat, senior neurologist in the city. So, kindly occupy the dais, please. Request my colleague to present a bouquet in honor of Dr. Ashok Sirsat. Dr. Ashok Sirsat served as associate professor at Grand Medical College, and currently he is practicing at Leelavati and Holy Spirit Hospital, and also at Malad. He is very well known in this part of the city. And now the sequence would be this, that first we would request Professor Black to give his oration, followed by there will be I will have a very small talk on the work which we have done at ipca on Chlorthalidone low dose, and then we would leave much time for panel discussion. Thank you.
Namaste. Namaste. I'm going to answer 2 questions that I know you're going to ask me, so I'll start by answering them. This is not my first trip to India. I was here in 1971 for the only prior trip was in Calcutta as part of the Johns Hopkins cholera unit that was there. As you heard, I was an author of JNC 6 and JNC 7, and to answer your other question, I'm not involved in JNC 8, and I'm proud of not being involved. I have no idea no idea at all when they're going to come out with that. It took us 3 months to finish JNC7. They've been at this one for almost 3 years, so we call it JNC late or JNC wait. We should probably call it JNC 9 by the time they get around to it. So I want to begin by talking about the importance of hypertension compared to other risk factors. This is a slide from 2005 looking at global mortality and the burden of disease you can attribute to cardiovascular disease and other risk factors. I think, as you can see in the blue, that for mortality and for the burden of disease, hypertension is the most important of those factors. Similarly, if you look at the global impact of hypertension with respect to a developing country or a developed country, that hypertension is more important and has a bigger impact than does tobacco, cholesterol, overweight, physical inactivity, or alcohol. And yet, in many ways, people take hypertension for granted. They think it's solved and don't need to worry about it. Well, I can't imagine anything that could be more wrong. What I want to show you on the next few slides is very recent data from the United States. You see, this is the 2012 update, just published earlier this year. Coronary heart disease contributes about half of the cardiovascular disease mortality, stroke about 17%, heart failure 7%, and hypertension by itself only 7%. But I think, as we all know now, hypertension is a major risk factor for coronary disease, for stroke, and for heart failure, and so has an enormous impact on outcomes. In fact, it's now estimated that every day 2,200 Americans die of cardiovascular disease, every day. That's much more than cancer. Cancer seems to be what people are afraid of, but it's heart disease and cardiovascular disease is what kills them. Alzheimer's disease, down here at the bottom, is only attributable to, it only attributes about 82,000 deaths. But I think most of us, we have a neurologist here, really have a strong feeling that hypertension and Alzheimer's disease are linked. Epidemiologically, it's a little difficult to say or to prove. Unfortunately, we can't distinguish multi-infarct dementia, which is definitely related to elevated blood pressure, from Alzheimer's. And we've not been able to show that reducing blood pressure prevents Alzheimer's. In fact, in the SHEP study, which I'll talk about in some detail, every center had a psychiatrist and a neurologist. And we looked carefully, and anybody we thought was demented or we thought had an issue that was related to strokes had to be examined by one of those physicians. And we could not show that we prevented the development of Alzheimer's with our treatment. Now, this looks at cardiovascular disease, again, in the most recent survey, 2005 to 2008. Pink is women, blue is men, and as you can see, once you get to 80 years of age, the percentage of the population that has cardiovascular disease is more than 80%, and more so for women than men. But in fact, by the time you get to age 60 through age 79, that's also the case. I now want to focus a little bit on stroke. 80-year-olds and over, about 15% of both men and women have had a stroke. I want to take a little poll now. You know, you just had an election here, so you're probably used to polls. We're having one in the United States in November, and we've had many so-called primaries on the way, and it seems all we're hearing about is what polls are telling us. So here's the poll, and everybody has to participate. No abstentions are going to be allowed. So imagine with me that you're going to wake up tomorrow morning having had a stroke or a heart attack, one or the other. How many of you, if you had that choice, would want to have a stroke as what you woke up with? How many a heart attack? Well, that's what I always find. I've never met any individual at all, anywhere, no matter how many times I ask this question, who would choose to have a stroke. One thing I think you'll notice, too, if you look carefully at outcomes in modern clinical trials, recent ones, there are almost as many strokes as there are heart attacks. Used to be about 5 times the number of heart attacks than strokes. And I'm pretty sure that the use of statins has reduced the heart attack rate. And we already did that with blood pressure. Whether we can reduce it further is an open question. Now, hypertension, too, is extremely common, especially in older people. In fact, once you get to 75, about 80% of women and about 2/3 of men are hypertensive. One of the things that the Framingham Heart Study, studying lifetime risk, has found is that if you get to age 65, not having been hypertensive, and live another 20 years, your likelihood of becoming hypertensive is almost a certainty. So as populations age, and you'll be doing that soon, if not already, you'll see more and more hypertension, and we've got to be extremely competent at taking care of it. I want to show you one new analysis from 2011. On the left in blue are a series of trials looking at the relative risk of stroke, and on the right in pink, the relative risk of myocardial infarction. It's pretty clear that there's a direct relationship, and a powerful direct relationship, between the difference in systolic blood pressure when you compared one group to another, placebo or active therapy. No question. And these are small differences. On the right, you can't find the same relationship for myocardial infarction. There's, in fact, really no particular relationship. So on the top, a 5/2 difference in blood pressure substantially reduces the rate of stroke. Highly statistically significant. Not so for myocardial infarction. That same blood pressure difference has really no impact on preventing myocardial infarction. What this should lead us to think, I think, is maybe these aren't really the same disease. We've always assumed that atherosclerosis hits this vascular bed or that vascular bed, but it's all the same. Maybe they're not all the same. Maybe there are different factors that lead to one or the other. And since we all agreed that stroke is something we shouldn't ignore, in fact, we should be concerned about, we've got to keep that in mind. Now, I want to quote a little bit from this most recent guideline from the National Institute for Health and Clinical Excellence, the NICE group. That's kind of a typical arrogant British term of clinical excellence, that they can tell that from everybody else. NICE, I'm learning, has access to a gigantic database from the National Health Service, and they have the ability to analyze it, something that we all don't have. So we've got to take their recommendations pretty seriously. They said if a diuretic is required, choose a thiazide-like diuretic, such as chlorthalidone, 12.5 to 25, or indapamide, 2.5 milligrams once a day, in preference to thiazides. This term thiazide-like diuretic This is something that we did in JNC 7. There were 9 of us who wrote that guideline, basically. It took us 3 months. And 4 of the 9 all had principles. All had just come out. And chlorthalidone, as I'll show you, was the diuretic in all had. We didn't want to say use chlorthalidone, even though I think most of us wanted to, since American doctors and doctors worldwide didn't use chlorthalidone. That would have been, what we'd like to say, that guideline would have been dead on arrival. So we coined the term thiazide-like or thiazide-type diuretic instead. We really meant, I'll tell you, it was chlorthalidone, but we didn't say that. So now I'd like to borrow from Charles Dickens and tell you a tale of 3 studies. The Mr. Fit study, which I wasn't part of, but all hadn't shown that I was, and try to go through those 3 studies in some detail. The first is Mr. Fit. Now, Mr. Fit, Jerry Stamler was the father of Mr. Fit, really, and he didn't like that term. He preferred to call it MRFIT, but he probably should have agreed to call it Mr. Fit because it was only men. The objective of Mr. Fit was to test a special intervention, which could be chlorthalidone or hydrochlorothiazide, compared to usual care in close to 13,000 high-risk men who were young, 35 to 57. The primary outcome was coronary heart disease mortality. Mortality is a difficult endpoint to prove. So what the investigators were asked to do was to achieve and maintain diastolic pressure. This was a diastolic-centered study between 80 and 89. They compared so-called usual care to special intervention. Now, what the usual care group was, and this is important to bear in mind, people were screened, were assessed to be high risk, and were told to come back in 2 years and 4 years. They weren't seen in between. The information about their risk was given to them and to their doctors. The special intervention group got dietary advice, smoking cessation advice, and a diuretic-based treatment that could be either chlorthalidone or hydrochlorothiazide at doses we now consider way too high. The choice of that diuretic was left up to the individual physician or the individual clinic, and then we added, or they added, serpine or hydralazine or guanethidine to get to that goal. So this was the only trial that allowed a choice of a diuretic between hydrochlorothiazide or chlorthalidone. It wasn't mandated. There were 22 centers in Mr. Fit. 6 of them chose to use chlorthalidone. 9 of them chose to use hydrochlorothiazide. And the others mixed it. So you could look at this, if you wished, as 22 different studies that were put together. The diuretic choice was not random, but haphazard, and each clinic tended to use one or the other. That was how it was designed. The important thing is, and why chlorthalidone, is to look at this next bullet. 4 years into the study, the Data and Safety Monitoring Board, the DSMB, told Mr. Fit investigators that they had to convert all special intervention participants who are on hydrochlorothiazide, they had to convert them to chlorthalidone. I've been on DSMBs, I've been on Accomplish, I was chairing of that, and I've been in Values DSMB, and we have the responsibility as a Data Safety Monitoring Board to have unblinded data, and if there's something we notice that favors or harms a group of patients or subjects assigned to one or the other, we have the responsibility to say so. Now, why did they do that? Well, if you look at this graph, in blue is the usual care group, and in orange is the special intervention group. And it does look as if, by the long-term follow-up of the study, which lasted about 10 or 11 years, that the special intervention group was doing better. But if you look down here, you can see these lines are very, very similar. That's when the mandate came out to switch. Well, here again, if you look in blue at the hydrochlorothiazide group, before they were changed for other cardiovascular disease and all cardiovascular events, the hydrochlorothiazide group was actually doing worse than placebo. So when the switch was made in orange, everything improved except non-cardiovascular disease. So that was the genesis of that recommendation. Blood pressure was better. And if you'll notice, this is a 2011 paper, not one that was done contemporary to the study. This is Mike Ernst from Iowa, who got very interested in chlorthalidone in particular. And since this was public information, they could get that data. Left ventricular mass as well was lower in the people on chlorthalidone compared to those who were on hydrochlorothiazide. Now, this is specific information from 48 months or 84 months, which showed the benefits of chlorthalidone. The systolic blood pressure and diastolic blood pressure were both statistically significantly lower. Left ventricular mass was better, and serum potassium was a little lower as well, but only 0.1 milliequivalent per liter. At the end of the study, the special intervention group was doing better than the usual care group, but this was not statistically significant, nor was, in fact, all-cause mortality. If you look at this last few years, chlorthalidone compared to drugs stopped was significantly better, as we would anticipate. Hydrochlorothiazide was better as well. But if you compare on the bottom row here, if you compared chlorthalidone to hydrochlorothiazide, chlorthalidone was statistically significantly better for event-free survival. So that's why it became the National Heart, Lung, and Blood, who was the sponsor of this and the sponsor of SHEP and all that. That's why it became their diuretic. Now, I was a SHEP investigator. There was 16 centers, and there was concern at that point, which I think many of us still have, that lowering systolic blood pressure in older people, I don't call them elderly anymore. I was the youngest PI in SHEP. Now I would qualify for SHEP, so I don't like the term elderly any longer. You were afraid that you would reduce perfusion and you would reduce cognitive function. I think all of us have an anecdote of an older patient we treated for hypertension who passed out or fell and broke her hip, and it's usually her. And so that anecdote sticks in our mind. We don't know about all the events we prevent. And in fact, there were analyses done, epidemiological analyses, that treating isolated systolic hypertension was going to be harmful, not helpful. So the hypothesis was that treating patients, subjects like that, would reduce the risk of stroke. That was the primary endpoint. This was a large cohort, 4,700 men and women, 43% men, 14% African American. They were all at least 60, and they had isolated systolic hypertension defined as more than 160 and less than 90. That's who we were looking at. The primary outcome was stroke, but we had a long list of other things that we looked at as well. Here's the protocol, and it's important to understand what we did. After the qualifying visits, there were several qualifying visits that took about 2 months. We started the active treatment on 12.5 milligrams of chlorthalidone with a matching placebo. If you were at goal, and I'll talk about that later, you stayed on that throughout. If you weren't, you were titrated to 25 milligrams. And if you got to goal, you stayed on that. And if you weren't at goal, atenolol, or if you couldn't take atenolol, reserpine was added, and hydralazine after that. So that was the way the study was designed. Well, here's the answer. There was no question, highly statistically significant reduction in fatal and non-fatal stroke. The study was planned to last about 5 years, 5.5 years. The statistician, Janet Wittes, was so good that her predictions of when we would reach that endpoint were only off by 3 weeks. So in fact, we didn't need to do the study at all. We just should have asked Janet what to do, and she would have told us. Well, it wasn't only stroke that we improved. That's at the top. But also coronary heart disease, heart failure, and cardiovascular death. All were benefited by the active therapy compared to placebo. Not all-cause mortality, because when you look at a group like this, there's a lot of competing risks, and all-cause mortality is hard to prove. Notice, too, that coronary heart disease was reduced by about 20%, 25% in fact. This is important when we get to all that. So the blood pressure in the active group was 26/9, lower than baseline. The blood pressure in the placebo group was also lower, 15/5, partly because a lot of the people in the placebo group had rescue therapy with active treatment, which we had to design for safety reasons. The goal, and this was what the investigators were to get, if your was a systolic of less than 160, if you began at 180 or more, or a reduction of 20 millimeters of mercury if your baseline was between 160 and 179. Different goals. The active group, 65% to 72% were at goal. The placebo group, only 32 to 40% were at goal. The average blood pressure when we were done was 143/68 in the active group and 155/72 in the placebo group. What's particularly important, I think, is shown here. Stroke was reduced by 37%, just as you would expect in a hypertension trial. It's almost predictable. In fact, it is predictable. And all kinds of strokes as well. What's important, I think, is for every millimeter of mercury decrease in systolic pressure, stroke incidence went down by 1%. What about the low potassium? That was a concern, I think it still is, of using chlorthalidone. In fact, we provided potassium supplements if required. So this is 4 years. In the active group, is in blue. Serum potassium dropped on average about 0.4 milliequivalents per liter by the 4th year. However, if you were on 6.25 milligrams, and we did provide that if requested, the drop in serum potassium was very small. It was only when you got to the full dose, the 25 milligrams, that you saw the average potassium being less than 4. We also looked to see whether that was really harmful. For those 151 of the active therapy group whose potassium fell below 3.5, we looked at coronary cardiovascular disease, coronary heart disease, stroke, and all-cause mortality. And in every instance, if you were 3.5 or more, the hazard ratio was favorable and down. So if you need guidance as to where to go, keep the potassium above 3.5. Now, what about the other metabolic effects? I think we all know that diuretics supposedly will cause diabetes. were we in fact causing diabetes? John Costis, who I think was the second youngest, or the next youngest CHEP investigator, looked at the long-term likelihood of patients with and without diabetes. What he found was really very interesting. On the left is the placebo group, and on the right is the active therapy group. The red bars are people who had diabetes at baseline. The yellow are those who developed diabetes on treatment, and the green are those who didn't have diabetes. What he showed was that if you got diabetes on treatment, you had the same mortality as if you never got diabetes at all. Not so in the placebo group. This calls into question whether or not the metabolic effects of diuretics, which tend to raise serum glucose, have the same impact as whether you had diabetes at all. Now, this is a good example of where we have a continuous variable like glucose, and then we categorize it, turn it into a categorical variable. You hit a glucose of 126, you have diabetes. If you hit 125, you don't. That really doesn't make sense, but that's how we do it. Well, John was still at it. This is very recent, the end of 2011. And he wanted to see whether there was a legacy effect of being treated. The lipid people do this all the time. You're treated for high cholesterol, and the study's over, and then you look at what happens years after the study ends. That's called a legacy effect. So he was determining the effect of blood pressure lowering in CHEP, whether that was associated with long-term outcomes, cardiovascular and all-cause mortality, and life expectancy. 22 years is pretty interesting since these people averaged in their high 60s. Well, I call your attention to this area. This is cardiovascular death, which you can determine in the United States on our national death index. So what he found was that those on active treatment, long after the study was over, lived 516 days longer than people who were in the placebo group. 516 days, almost 2 years longer. And if you look at all-cause mortality, they live 205 days longer than people on the placebo group. Why that is, how that is a little hard to tell, but those 5 years of active therapy had a very important legacy effect. Which brings us to the third study I want to discuss, which is ALLHAT. There were 9 regional coordinators in ALLHAT. I was one of them. I had responsibility for 93 centers, mostly in Illinois and Texas. I don't know why those 2 states, but that's what we got to do. And the hypothesis here was that the occurrence of fatal and non-fatal MI would be lower with newer agents, CCBs, ACE inhibitors, or alpha blockers, compared with a diuretic. Now, why did we do something like that? That was an important question. A meta-analysis of clinical trials done in 1990, before ALLHAT started, said that we would expect treatment of hypertension would reduce strokes about 40%. That was the estimate, and that's exactly what was achieved. We saw it here as in every other study too. But when you look at myocardial infarction, the estimate was that it should reduce MIs about 20 to 25%, but only reduced it 8%. So what was that shortfall due to? Why did you not do as well for MI as you did for stroke? At that time, I think there was no appreciation that these may be different things. So one of the hypotheses was that it was the drug that was in those studies, namely diuretics, that were responsible for that shortfall. That's what we were testing. So we had 42,000 subjects. That's certainly the largest hypertension trial ever done and probably ever will be done. They were in 623 centers. Everybody was at least 55. The mean age was 67. And they had to have untreated blood pressure as you see it, or treated blood pressure here. And the hope was that one drug or two would be all they needed. We had 47% women. Mostly when you do studies of people of this age, you get more women than men. But one of our centers was a VA center, a Veterans Administration Center, which has very few women. There were 35% African Americans. This is a question we've been asked: why did you have so many African Americans? Well, in fact, we wanted 55%, not 35%, because we felt this was a group that's been understudied. And 35% diabetics, so there are 15,000 diabetics in ALLHAP. So after you had the blood pressure qualifications, you needed at least one other risk factor. Here's the long laundry list of risk factors that could qualify you. And unfortunately, one of the things that we will never know is how many people had 2 or 3 or 4 risk factors. Because once you had the right blood pressure and you found one of these things, you didn't need to note or record the others. And investigators, I think if you've been one, you know that as soon as one of your potential subjects qualifies, you're happy, you're done. So we don't know really how many people had 2 or 3 or 4 risk factors, even in retrospect. Here's the protocol, probably familiar by now. High-risk hypertensives who were consented got either amlodipine at 2.5 to 10 milligrams, doxazosin 2 to 8 milligrams, probably should have been 16, and lisinopril 10 to 40 milligrams. These were the representatives of the CCB, alpha blocker, and ACE inhibitor class, and chlorthalidone from 12.5 to 25 milligrams. One thing that should occur to you is, how come we had so many more chlorthalidone people compared to the others? Amlodipine, doxazosin, and lisinopril all had over 9,000 subjects, and chlorthalidone group had 15,000. That's because what we were doing was comparing each of those drugs to chlorthalidone, and that needed to be a larger sample size. In fact, the randomization was 1.7 to 1 for all of them, and that's what we got. There's also, as you see, there was a lipid-lowering arm. We don't talk about that much anymore. That's what the LL and ALLHAT stands for, lipid-lowering, because we didn't really find much. And you may not recall that the HOPE study also had a vitamin E arm that didn't show anything. So these factorial trials sometimes show one thing, and we tend to ignore the other. The question we were asked most when we presented this study to the world was, why didn't we use a beta blocker? That was a first-line option. Well, there were a couple of reasons. The main one is that we needed a second drug to add to what the first drug was. So anytime I got that question asked, I would take a mirror and turn it around and ask the person who was asking the question, well, what would you have picked as a second drug that you could add to everything else? I never got a satisfactory answer, so it was a beta blocker. More importantly, on the bottom is that current recommendations at that time, this was in the late 90s, was that you didn't use beta blockers as initial treatment for older hypertensives and African Americans. And as you can see, we had basically older hypertensives in many African Americans. That's why there's no beta blocker. The primary outcome was, as I said, fatal coronary disease and non-fatal MI. And once again, there's a long list of secondary outcomes, including combined cardiovascular disease, and that's where heart failure was a part of a secondary outcome. We also looked at cancer. Why would we put cancer as an outcome in a hypertension trial? Well, that's because Kurt Furberg, who was a study chair, had been writing based on some poorly done work that calcium channel blockers cause cancer. You may remember that. And so we went to see if that was true. Well, here are the blood pressure results. Chlorthalidone's in yellow, amlodipine in red, and lisinopril in green. I want to call your attention to this. In the first year of the ALLHAT study, the chlorthalidone drop was much more dramatic than the other two, especially in African Americans. When we looked at the data later on, what happened at the beginning turned out to be quite important as to what happened at the end. So in ALLHAT and in ASCOT and in LIFE, the change in systolic pressure in the first 6 months was important in reducing events. Now, I'll tell you a little story. I was on the value DSMB, and I knew that was going to be the case. Value was still going on when we were writing JNC7, and so I couldn't reveal that. So basically, what I did or helped to do was to start our stage 2 patients, 160 or 100 or more, on 2 drugs to try to get prompt reduction in blood pressure. Not urgent, not emergent, but prompt within, say, 3 to 6 months, not to spend time, because that really turns out to be important. Well, here's the primary endpoint. You don't need a statistician to tell you that these are all the same. So some people who didn't understand what ALLHAT was about said, well, you didn't show anything. You didn't prove the chlorthalidone was better. That was not what we set out to prove. We set out to prove that the other drugs were better, and they clearly were not. So we showed our primary endpoint, different from what people expected, but there it is. When you look at stroke, it's clear, too, that chlorthalidone is better. Amlodipine is pretty good, too, but not lisinopril. When we looked at the combined cardiovascular disease, remember that included heart failure, it was a bit of a surprise. Chlorthalidone actually was statistically significantly better than the ACE inhibitor. That concerned some people. There are some people who worship at the ACE inhibitor shrine or the RAS blocker shrine, and what did we found that wasn't the case. When we looked at heart failure as well, lisinopril was not better than chlorthalidone. That was a surprise. Remember, we give an ACE inhibitor to people who have heart failure. So how do we rationalize that? Well, we had 2,200 events, heart failure events, and what the investigators did was, if they thought it was heart failure, they said heart failure. They had a score to fill out, a Framingham and an ALLHAT score. And so people said, well, that really wasn't heart failure at all. It was just edema. You overcalled it. And that's why doxazosin wasn't successful. Well, if that were the case, amlodipine would have been a problem as well, and people didn't say that. So what we did is we took all the charts of all these individuals, showed them in a blinded fashion to 2 groups of cardiology fellows, one at Baylor and one at University of California in Los Angeles, and asked them to say whether this was heart failure by actually reviewing the chart. They agreed with the investigators more than 80% and agreed with each other almost 100%. I know of no other study that worked so hard to be sure that what was called heart failure really was heart failure. What about kidney disease? ACE inhibitors, too, are supposed to be special for kidney disease. So these were the renal outcomes, that is, end-stage renal disease or a doubling of GFR when you compared lisinopril to chlorthalidone. There was a trend favoring lisinopril, but it wasn't statistically different. And if you look at fatal and non-fatal CHD and MI, in patients with renal disease. Here again, chlorthalidone was just as good as lisinopril. Now I want to drill down to some of the details. This is something that you should sort of do when you take a big trial like this, is to try to understand as much of what was found. On this slide and the next couple, the chlorthalidone group is on the left, amlodipine is in the middle, and lisinopril is on the right. First of all-cause mortality was actually lowest in the amlodipine group. So Dr. Furberg was wrong. Calcium channel blockers were not killing people, as he told us they were doing. Secondly, for coronary heart disease or cardiovascular disease, the highest rate happened in the ACE inhibitor group, not in the other two. And when you look at end-stage renal disease, another thing that ACE inhibitors were supposed to be especially good at, the lowest rate was in the diuretic chlorthalidone group, not in the ACE inhibitor group. This is all different from what people thought, and some of the reason that all that got such unpleasant pushback. When you look at fatal outcomes, here again, lisinopril for heart failure was exactly the same as chlorthalidone was. And when you look at other events, there wasn't any increase in cancer in the CCB group. In fact, it was lower. The one thing that was highest in the chlorthalidone group was injury, suicide, and homicide. Now, when you see a result in an epidemiological study or in a trial, it has to make biological sense, or it's a chance finding that's not important. And I've been trying to figure out why chlorthalidone would cause suicide and homicide. The closest thing I can imagine is that maybe that men were getting up in the middle of the night on chlorthalidone and they got shot by their wives for waking them up. That's as good as I can do. So we look at stroke rate now. Here again, a statistically significant increase in the lisinopril group compared to the other two. When you look at combined cardiovascular disease, here again, there's a 10% increase, statistically significant, that favors chlorthalidone against lisinopril. For heart failure, however, amlodipine is certainly worse, but lisinopril was not really better for heart failure, even in the top, which is fatal, non-fatal, and hospitalized or treated, or on the bottom, which is hospitalized and fatal heart failure. Surprising results. Now, we had subgroups. These were all pre-specified. And any trial that doesn't pre-specify a subgroup is always accused of data dredging. You look until you find some result you like. The Australia study came out about the same time, told us that ACE inhibitors were better for men than women. Yet that wasn't a prior hypothesis. That was data dredging. So here too, for non-fatal MI, coronary heart disease death, amlodipine on the left compared to chlorthalidone, and lisinopril is on the right. No differences. Diabetic or non-diabetic was the same. When you look at stroke, here again, the group that had a statistically significant benefit from chlorthalidone were the blacks. Non-blacks were the same. Now, it was the blacks that had the biggest one-year drop in blood pressure. So I'd like to think that that was probably the reason. Note, too, that there's no advantage in diabetics or non-diabetics of the ACE inhibitor. So one of the things that the Prospective Collaborative Studies group has told us, or one thing we probably all said before that, is in an older patient, go slow, not too low. I'm guilty of having said that. So what they said, based on the data you saw, is that at least for stroke, main changes in risk may occur quite rapidly, so in the change in usual blood pressure. So this isn't talking about urgent or emergent treatment. This is talking about prompt treatment. We shouldn't waste time. When you look at combined cardiovascular disease as well, here too, both the blacks and the non-blacks did better on chlorthalidone. And there's no advantage in the diabetics even for this endpoint. That was a surprise as well. For heart failure, though, it's quite clear amlodipine was harmful in all of the subgroups, and chlorthalidone was better than lisinopril in all of the subgroups. Surprising results. Now, why are people so surprised? I think if you remember the SOLVE study, which was published in 1991, this was with enalapril. SOLVE had two studies, SOLVE treatment and SOLVE prevention. SOLVE treatment showed the benefits of enalapril in preventing second new heart failure once you had it diagnosed. The SOLVE prevention study didn't show any benefit in preventing heart failure. So that's comparable to all that, and it should not have been such a surprise. Well, what's the good of giving a drug that has all these great benefits if you have too many side effects? When we analyze adverse reactions to drugs, and I just got through being on the FDA panel for 4 years, we look at not adverse events reported, but we look at adverse events significant enough to discontinue treatment. And that was also highest with the ACE inhibitor. More people stopped the ACE inhibitor than either of the other two drugs, for the blood pressure being both too high or too low. Surprise. What about the metabolic effects? Well, we're worried about the metabolic effects. 8.5% of people had a serum potassium below 3.5. We already talked about it. That wasn't a good thing. And we provided potassium supplementation. GFR, in fact, was not lower in the chlorthalidone or lisinopril group. It actually did best with amlodipine. So the use of potassium supplementation is shown here in the yellow bars. This is chlorthalidone, and by the 6th year, 11% required potassium supplementation. It was also evident in the other two as well. That's not very much. If you look at diabetes incidence here at the bottom, it was about 12% in chlorthalidone, about 10% in the metabolically neutral CCB, and about 8% in lisinopril. But this is based on a glucose value, not necessarily anything else. So to summarize all that, what was said is there was no difference in the primary outcome between the three drugs tested. Doxazosin was stopped early really for two reasons. There was an increased risk of cardiovascular disease and heart failure compared to chlorthalidone. And the second reason was what we call futility. There was only a 1% chance that the doxazosin group would ever have shown its primary hypothesis being proven, and so it didn't make sense to go on. It's not recommended for first-line therapy. One of the very interesting things for people who care about outcomes, as I do, is that the drug that had the best metabolic profile with respect to glucose and lipids was doxazosin. Didn't have the best outcomes. It had the worst outcomes. Blood pressure control was best with chlorthalidone compared to the other two. So thiazide-type diuretics, that same term again, were at least as good and often better in preventing major cardiovascular disease in all demographic subgroups, as you saw. The metabolic differences were present, but these did not translate into more events or a higher all-cause mortality. So the last question I want to pose and try to answer is, how come? Why is chlorthalidone better than thiazides? There were two basic reasons. First could be pharmacokinetics and pharmacodynamics. As you'll see, it's a longer-acting drug. It works better at night. Or it could be so-called pleiotropic properties, and I'll show you what I mean by that, especially effects on carbonic anhydrase, inhibition, and what that has to do with platelet aggregation and vascular reactivity. But probably we don't really know why that is. We think we do sometimes, but maybe we're not so smart. When we did JNC7, we had a very good supporting group, and we had this question to face: should we recommend chlorthalidone or hydrochlorothiazide, or not make any difference? So we carefully looked at all of the papers that had compared those two drugs. The last ones were 1979. It was only later on that people began to look at this question, and Mike Ernst again did this in 2006. What he found was that the 24-hour blood pressure and the nighttime blood pressure were much better controlled with chlorthalidone compared to hydrochlorothiazide. It's, after all, a long-acting drug with a half-life or dosing utility of more than 24, sometimes as long as 48 hours, and hydrochlorothiazide only works about 12 hours. We used to not worry about that because, after all, people were asleep and their blood pressure went down, so you don't want to give a 24-hour drug. Well, that may not be the case at all. What this group also showed, and Barry Carter, it's from the same university, is the idea that chlorthalidone was twice as potent as hydrochlorothiazide. So to get an 18 millimeters systolic drop, you need 25 milligrams of chlorthalidone and 50 milligrams of hydrochlorothiazide. And they did this with ambulatory monitoring. So daytime blood pressure was the same in the two groups, but nighttime blood pressure was clearly better, statistically significantly better, 0.009, in the group that got chlorthalidone. And I don't think our arteries care whether they get the barotrauma from a forceful contraction at night or during the day. It's all the same. It's like pack years and smoking. It's sort of millimeter hours. Our group did a very simple study. George Backris, who was part of my department, along with Bill Elliott. What we did is took patients on a dose of hydrochlorothiazide, usually 25 milligrams. That's the most we used. And we simply switched them to chlorthalidone and looked at the blood pressure effects 8 weeks later. Went from 152 to 144. Did nothing else, just changed the diuretic. And many of you probably have had that experience of stopping a thiazide and using chlorthalidone and seeing blood pressure drop. Someone told me about that earlier today. Now, the last thing is, what about carbonic anhydrase activity? This seems like a peculiar thing to look at. And it came, in fact, from a surprising place. This is a 2010 study from the Naval Base at San Diego, California, a place you didn't think would be doing basic research. So this is vehicle in blue. This is a thiazide, benzoflumethiside. This is chlorthalidone in orange. And that's acetazolamide, which is a carbonic anhydrase inhibitor. And you notice there's a big difference between how much you reduce carbonic anhydrase activity. So what? Who cares? Why would that matter? Well, it may matter because if you look at epinephrine-induced platelet aggregation, it's reduced by chlorthalidone and not by the thiazide. And this may explain some of the reason why you see different outcomes. So carbonic anhydrase dependent exchange may be important to mediate catechol-induced platelet aggregation or increases in vascular tone. Increased activity may make it more difficult to inhibit carbonic anhydrase and the responses associated with it. And chlorthalidone inhibits it better, substantially better, and maybe that explains why the outcomes seem to be superior when you look at them. So I want to close with our report card. How are we doing in the United States right now with blood pressure control? Awareness is in blue, treatment is in yellow, and at goal or controlled is in green. What our national goal was to get 50% of hypertensives at goal. This is 2008. We're pretty close, 48%. This is the case in non-Hispanic whites, non-Hispanic blacks, but not yet in Mexican Americans, which is the only Latina group that we have any data. We have no data on South Asians or East Asians. That's going to have to come from here. So is that very good? Doesn't sound very good, really, only 50%. But if you look at where we started, it was about 22%. So we have made some progress. I'd like to close by inviting you all, if anything I said tonight is even the slightest bit interesting, to come to the next ASH meeting, which is May 19th to 22nd in New York. The Empire State Building is still there, and we'll have it at the Hilton Hotel on 6th Avenue. Thank you very much for your attention.
Thank you, Professor Henry, for giving us an insider insight into the landmark studies involving chlorthalidone. Now, I would just briefly touch on the Indian experience, small work which we have done. There is a cardiovascular epidemic in India with increasingly younger population we are seeing with hypertension, pre-hypertension, diabetes, pre-diabetes, and dyslipidemia. And hypertension continues to play a pivotal role in this. Need for tighter control of blood pressure is obvious when hypertension is associated with comorbidities like coronary artery disease, diabetes, CKD, CHF, and stroke. Why thiazide type diuretics? Because hypertension largely remains undiagnosed, undertreated, uncontrolled, and majority of the patients will eventually require combination therapy to achieve control of blood pressure. And in a combination therapy, the role of thiazide type diuretics becomes important. I would like to say that there is tremendous underuse of thiazide-like diuretics, not only in India, but even in developed countries like US and even Europe. There is a tremendous underuse of thiazide-type diuretics, and it has more to do with promotion of the drug and a lack of awareness among physicians, basically, that severe risk reduction is done convincingly with thiazide diuretics as good as any other class of drugs. And that has been very convincingly demonstrated by Professor Henry. There has been excessive emphasis on metabolic adverse effects. Although with the low dose thiazide type diuretics, you will have these concerns are reduced to a great extent. And there is some misconception that thiazide type diuretics are not suitable for Indians. Although when we noticed that AC inhibitor and ARBs alone, they are selling much less in India as compared to when they combine with hydrochlorothiazide, and 12.5 milligram hydrochlorothiazide continues to be most widely used in India in combination with AC and ARBs, and there the hyponatremia cannot be taken care of by this combination. By the time we would have seen a flood of hyponatremia, but that we don't see. Evolution of chlorthalidone in the 60s and 70s, very high doses were used, but gradually the doses are coming down. And now we are looking at even a dose of 6.25 milligram. How we conceived this dose was for hydrochlorothiazide, 12.5 and 25 is considered as the low dose. And since there was some data that it is 1.5 to 2 times as potent as hydrochlorothiazide, we thought why not look at 6.25 milligram and see how it compares with 12.5 hydrochlorothiazide. I think these points have already been touched by Professor Black. One expert is among us today who has already given his opinion. Now we have other experts like Norman Kaplan who commented all these experts have commented in 2011, although surprisingly OLED study was published in 2002 December and JNC guidelines were given in 2003, but the experts commented in 2011, and the NICE Committee on Hypertension commented in 2011 that prefer chlorthalidone in place of hydrochlorothiazides. And Norman Kaplan said that millions of hypertensive patients have been given a less effective drug like hydrochlorothiazide, And if would have used chlorthalidone in place, would have saved more lives. And similarly, effect on LVH and the other opinion. India being a very high incidence of diabetes in our country and metabolic syndrome, does chlorthalidone fit in this? I would just like to point out the available data in SHAPE, where chlorthalidone lowered CV events both in diabetic and non-diabetic to the extent of 34%. But absolute risk reduction with chlorthalidone was twice as great in diabetics as compared to non-diabetics. In the ALLHET study, there was a sub-study was published with in people in ALLHET who had metabolic syndrome, and chlorthalidone initial therapy offered similar or possibly superior cardiovascular disease outcomes in people with metabolic syndrome. We have done 3 clinical studies with 6.25 milligram chlorthalidone in Indian government medical colleges, involving first study 300 patients, where what we did was in people with hypertension, mild to moderate, where we used approved low dose of atenolol 25 milligram, approved low dose of amlodipine, that is 25 milligram, and compared it with 6.25 milligram chlorthalidone. And after 4 weeks, patients who were not controlled, then addition of atenolol 25 milligram was done in these patients. What we noticed was with all 3 groups, there was roughly 50% patients who achieved the goal BP. So remaining 50% we added atenolol 25 milligram to all the 3 groups. And we noticed a similar fall in both systolic as well as diastolic blood pressure. And we noticed that statistically similar control of goal BP. Goal BP was achieved in similar percentage of patients in all the 3 groups. And electrolytes and blood sugar before start of the study and at the end of the study after 6 months, we did not find any change in both electrolytes as well as sugar level in chlorthalidone 6.25 milligram. The next study we did was a combination study where we used metoprolol succinate control release 25 milligram in combination with either 6.25 chlorthalidone or 12.5 hydrochlorothiazide. And then in non-responders, the escalation was done with metoprolol 25 mg. And what we noticed was there was a similar fall in both the groups, so slightly favoring chlorthalidone numerically, but statistically similar fall in systolic and diastolic blood pressure. And again, at the end of the 12 weeks period, we noticed there was not much change in the chlorthalidone or the hydrochlorothiazide group in electrolytes and blood sugar levels. Next study which we did was combining an ARB and chlorthalidone. This was the first study where an ARB was combined with chlorthalidone. And this study I presented at University of Mississippi Cardiovascular Renal Conference. There is definitely a merit in combining an ARB with chlorthalidone in terms of counter-regulatory mechanism on insulin sensitivity, renin activity, hypokalemia. And with losartan, there is a particular benefit in terms of uricosuric effect. And here what we did was we compared 2 doses of losartan 25 milligram with chlorthalidone 6.25 and versus losartan 25 with hydrochlorothiazide 12.5. And after 4 weeks, non-responders, what we did was here, instead of increasing the losartan dose, what we did was in the chlorthalidone group, we increased the dose of chlorthalidone, while in the losartan group, while in the hydrochlorothiazide group, we increased the dose of losartan. And we again noticed a similar fall in systolic and diastolic blood pressure. And again, there was no much major change in electrolyte or fasting sugar before at the end of the study. In the lipid parameters, statistically, there was no change in lipid parameters. So both treatments reported significant reduction in blood pressure. Non-responders to losartan, when chlorthalidone was escalated, the result was similar to escalation what was achieved with losartan escalation. There is a target organ protection with both the drugs, which has been demonstrated with major studies. uric acid and reduction and renal correction, I would like to just point out that in October 2011, a study the sub-study of renal was published, where they showed that because of its unique uricosuric effect, this offers an additional nephroprotective effect with losartan. So that was the conclusion there. So we have introduced the 6.25 milligram and tried in the Indian patients, and with availability of 6.25 milligram, we feel that there would be the pattern of underusers will change slightly better in favor of more users of chlorthalidone and chlorthalidone combinations. And thank you very much for your patient hearing. And with that, I would now request the panel members to kindly occupy the dais. I think Professor Goyal has left because he had to attend an emergency, but I would request the other panel members to kindly come on the dais. I would like to add that this CME program is watched live in 19 countries across the country, and we may get some questions from some other Indian cities like in Jaipur and various other places. This CME program is going on. And I think we have already received some questions from other cities. So that's just for your information that this program is at present conducted in 19 cities across the country live. First, I would request Professor Kripalani to give his observation and what is his opinion about the proceedings so far, and anything else he was like to add valuable comments.
Thank you for this. I think that you have both speakers, Professor Black and yourself, you have shown us quite convincing evidence which was already there in Al-Haq. And it's in fact surprising that over the last 8 years while Al-Haq has existed, no Indian company has really come forward to look at chlorthalidone. So also that even until 4 years ago, hydrochlorothiazide had been completely ignored, and you could only get it in combination. You couldn't get it alone. So thiazide and thiazide-like drugs have been ignored by the Indian pharmaceutical industry, and the trick seems to be the lowering of dose. I recall that I used to treat my father with hygrotone, which was the
Ciba-Geigy, yes. In 80s it was, yes.
And the dose was 100 milligrams, and he would faint, and he would get gout, and his blood sugar would go up. So it was, I think the drug fell in, both the thiazide-like and the thiazides fell into disrepute because of the large doses, and the smaller dose has made the big difference. And the two nice things that I learned from today's talk, one was the extremely good effect on stroke, which I think should be emphasized, and perhaps the mechanisms by which the chlorthalidone has been shown to be superior, the explanation on the platelets and the sensitivity of the vascular tone.
Thank you very much, Professor Kripalani, and I would request Professor Siddharth Das to now add his valuable comments.
Well, I echo what has already been discussed, but I would like to remind you regarding the Indian hypertension guidelines. 5 years ago, we had brought out the second Indian hypertension guidelines, and all the people all over the country who sat down and we had discussed this issue of diuretics. It was consensus that chlorthalidone is a good drug. It has been mentioned in the Indian hypertension guidelines also, but unfortunately at that time chlorthalidone was not available. So we have recommended at that time also that chlorthalidone has to be used. The other important aspect, I think each one of you over here must have agreed that as per the various trials, hypertension should be treated with more than 2 drugs for control of blood pressure. And hence, the drug of choice with any combination, I think diuretics comes much ahead. And with today's discussion, you must have realized that there is very little adverse effect, especially the metabolic effect, the uric acid action, and the other pleiotropic effects. I think chlorthalidone has a place in the treatment, and hydrochlorothiazide group of drugs also has a place along with the various group of drugs that we are using in combination for effective control of any hypertension, maybe with or without diabetes.
Thank you, sir. Now I would request Dr. Sirsat to give a neurologist's perspective on the whole discussion.
One undoubted a new phenomenon for me is the role of this drug as antiplatelet aggregant, and therefore its effectivity in stroke, in terms of incidence of stroke by people on this drug. What I see in my practice is a word of caution, because there are many family doctors in this audience. On diuretics, and especially in summer, our patients complain of what is known as vertigo. They use the word chakra, which means vertigo in almost any language. And therefore it may be a good idea, especially in summer, to monitor the blood pressure in the standing position. Far too often is the orthostatic hypertension associated with diuretic use. And as Dr. Kriplani mentioned, probably an inappropriate dose of the drug that leads to these symptoms.
I would request Professor Ajay Mahajan to, I think he has been a prolific user for us also, I think since we have launched, he would be a user's perspective there.
Yes. The most important thing about treatment of hypertension is that to gain some specific advantage from the treatment of hypertension, to reduce the primary as well as secondary endpoints, all-cause mortality or cardiovascular mortality, the most important thing required is we have to control the hypertension for 24 hours a day and 7 days a week. And for smooth control of hypertension 24 hours a day, we have to choose the drug which is having more than 24 hours half-life. And in each group there are certain drugs which are having more than 24 hours half-life. And those are the drugs, if you take the data of all the clinical trials, those are the drugs which are having more than 24 hours half-life. These are the drugs which are having significant impact as far as the primary as well as secondary endpoints. And if you want to choose the diuretic, then from all diuretics, the chlorthalidone is the only diuretic which is having maximum half-life, that is 42 to 72 hours. And because of that, we are having all positive data with only this diuretic when you compare with other diuretics. That is the most important thing about chlorthalidone.
Dr. Ratna Parke, kindly.
I think everybody has commented on all their subject experts. Rather, I have some queries. And most of the people here, they might be having those queries.
Sure.
Our personal experience with CTD is quite less than 6 months or at maximum one year. First thing, such a nice molecule according to all the 4 trials and even the Indian trials, such a nice molecule, and the efficacy of molecule was shown from 64 to 79, and after alert it was endorsed. Why this molecule didn't picked up to that level at which the hydrochlorothiazide has reached? One thing. Secondly, the extension of Dr. Mahajan's opinion. If the duration of action of plasma half-life is 45 hours, why not to give this molecule alternately? Because what our observation in Indian population, the electron imbalance is more pronounced than compared with the Western population. These are my few queries. And third, maybe contradictory, most of the trials with ARBs, amlodipine has shown significant drop in the blood pressure. In they mentioned 2-digit drop is like you get only with amlodipine or with telmisartan or olmesartan like ARBs group. And in these 4 studies, you are getting equal blood pressure drop. This is a little bit contradictory what the huge number of trials are there. So these are the queries to the panelists rather than my opinion.
Okay. About pharmacokinetics, what I would say is when you go into the prescribing information of chlorthalidone, which is there I think since 1960, you will see that the high doses have been recommended twice a week. But low dose, nobody has done any data, like giving 6.25 alternate day, that kind of data is not there. So unless and until you do a PK-PD correlation, then only you can recommend twice on that. I think Professor Black would be more appropriate to answer whether we can give alternate day or twice a week. But the higher doses, I know 100 milligram has been recommended twice daily because I've seen the literature of 1960. But on 6.25 or 12.5, there is no such studies are available on alternate day to my knowledge.
If I could just make one comment about that. If you look at the half-life of chlorthalidone, it's short. If you look at the duration of action, it's long. And part of that is because chlorthalidone gets into red cells and is released from red cells during that time period. We don't necessarily look at half-life now that we've done ambulatory monitoring. We look at duration of action. And my problem with giving it every other day is I think it's harder for people to remember, was this a day I was supposed to take it or not? And so taking it every day, as you see, doesn't really cause more harm. So we have to be sometimes practical about what we ask people to do. I think the issue about dose is pretty interesting, and I think there's another good example, which is aspirin. In my day, aspirin was the anti-inflammatory NSAID, and we gave 3 or 4 grams sometimes. Now we know that 81 milligrams is a very effective dose. We don't need that much. So we do change as we learn more.
Okay. Request participation from the audience and questions there. Yes, please. Dr. Gupta, please.
Excuse me. Good evening.
Sir, they say that the diuretics lose their potency of controlling blood pressure in the long term. Hardly 30% patients are controlled only with diuretic. So we have to add some other drug. And you say replace hydrochlorothiazide with chlorthalidone. And today, every antihypertensive drug is available with hydrochlorothiazide by all the companies, and it is being used by all of us. You name all the, not only here, all are using hydrochlorothiazide with ACE inhibitor, ARB, beta blocker, CCB, and I think we are all reasonably well controlled. We are all satisfied with that. So how can you say that you change hydrochlorothiazide with chlorthalidone, and why other companies are not coming out with this molecule when it is such a old molecule?
I think I understand your question, which is how come all the fixed dose combinations that include a diuretic have chlorthalidone, have hydrochlorothiazide as the dose. And I think that's a little bit about behavior of the pharmaceutical industry. The leader in the time of fixed dose combinations was Merck, and they made diuryl and hydrodiuryl. They made Aldomet, and that was the combination, one of the first ones to be introduced. The pharmaceutical industry tends to follow the leader. Very rarely are they innovative. And when we did advisory boards to companies that were making ARBs, and we would routinely say, use chlorthalidone, make it with chlorthalidone. Finally, one company did, and that was Takeda. So we now have introduced, just approved last week, azilsartan with chlorthalidone. If they're good at marketing, that's going to replace a lot of the fixed dose combinations that use hydrochlorothiazide. So I think our doctors are finally convinced.
Using chlorthalidone with losartan. Losartan is an outgoing drug. Nobody uses losartan nowadays. It should come out in combination with telmisartan, olbisartan, new ARBs. I think with losartan and atenolol or metoprolol, I think the newer ARBs should be used with chlorthalidone if at all they have to come in the market.
I don't know, was there a question there?
I am saying that why losartan, they have done study, losartan
we have taken your suggestion.
chlorthalidone.
I
Why not other ARBs?
I think they're willing to be innovative.
We have taken your suggestion, and we will come out with
that.
other combinations as well. But I would like to only add that if an old drug is better than new drug, we should not have any problem. Like aspirin is 200 years old. Do we have problem with aspirin? We can't. So So as long as the old drug is, is valuable, I think we need not have any problem with that. Losartan, despite if to your arrival of the other newer ARBs, which are definitely good, but if you see the amount of outcome data which is there with Losartan and the unique uricosuric activity, I don't think any other ARBs has that. I think you can, there are experts sitting here, they can comment, but so Losartan still continues to have its place in the armamentarium. I don't agree there that just because the drug is new, it should be preferred. It should be preferred on merit. That is what is my feeling.
Good evening.
Patient with significant LV dysfunction. Actually, US FDA had only approved Losartan, Valsartan for CHF patient rather than any other sartan. So if there is LV dysfunction or post-myocardial infarction patient where you want to treat the hypertension, the Losartan with the Chlorthalidone will be better option as compared to any other combination. The most important thing about accomplished trial, all negative data in accomplished trial is only because of hydrochlorothiazide. Menazepam with hydrochlorothiazide, all negative data as far as cardiovascular system and cardiovascular mortality is concerned. And all this that happened because of the adverse effect related to the hydrochlorothiazide. The biggest trial in 2008 which had substantiated combination therapy for the treatment of hypertension and achieving the targets.
But still it is most popular, being used by everyone. You say anything, but still it is most popular.
See, in European market, the highway trial is indapamide, but they brought the indapamide in extended release formulation 1.5 milligram, and that had clicked particularly in patients with the hypertension, elderly hypertension. They came out with the combination with the perindopril with the indapamide. So
I
the
think
same indapamide, the American counterpart of indapamide is Chlorthalidone.
I think now we move to other questions.
Is there any comparison study between Chlorthalidone and sustained release indapamide? Because I wanted to ask because they have a similar,
I'm sorry, if you're talking to me, I can't
is
hear
there
you.
any comparison study between Chlorthalidone and sustained release indapamide? Is there any advantage with Chlorthalidone over indapamide?
Comparison of indapamide and Chlorthalidone.
Yeah, it's interesting. In the same group that looked at Chlorthalidone for platelet reactivity, found the same results with indapamide. Indapamide is not a popular drug in the United States either. And this is all to some degree because of marketing. Those of us who follow what happens to drug acceptance, it's very much a question of marketing. Merck was a very good marketing drug. Their diuretic became the drug of choice. They were competing with a company called USV, which made hygrotin and regrotin, and there was no way that a small company like that could ever successfully challenge Merck, who was the big dog at the time. Merck was also wise enough when they introduced losartan as Cozar to also launch Hyzar, which had the hydrochlorothiazide combination, which made it a more powerful drug. So we'd like to think science determines a lot of what we do, but it's not. It's the science of marketing sometimes that does. I know of no comparison studies with indapamide compared to chlorthalidone or indapamide compared to any thiazide diuretic. They just haven't been done.
Dr. Black, Chlorthalidone we just discussed, the half-life is up to 72 hours. Do you envisage in the future a product which will be, say, once a week, some depot preparation or something? Have you been thinking on these lines? Do we have in future a tablet to be taken once a week? Are you working on it? Are you thinking?
Sorry, I didn't understand the question.
Once in a week antihypertensive, do you envisage? Once in a week antihypertensive, do you envisage in future any molecule which will be once in a week for hypertension?
Are we going to get a once a day?
Instead of once a day, once
Once
in
a week? No, I don't think so. I couldn't remember to take a once a week. Look what's happened with the agents for osteoporosis. They're once a week or once every 3 months or once a year. Maybe so, but I think the thing is, what we know about compliance or adherence to medication is to associate it with some event of your daily life. That seems to be the important thing. So if you take your pills in the morning when you brush your teeth, you'll remember to do it. If you've got to remember whether it's Saturday or Sunday you took it, I don't think that's going to help.
Professor Kriplani, please.
Well, you know, I think the point that Dr. Devi raises is valid, but you should see the downside of once a week dosing. We used to have anti-diabetic drugs, I don't recall the
Tolbetamide, I think.
which worked for 48 hours. And on a bad day, the patient didn't eat. You couldn't get them out of coma. I had one patient for 4 days was in coma and then finally died in coma. And the same thing applies to antihypertensives. Good as they are, if the patient gets diarrhea, you could send them into renal failure, particularly into the ACE inhibitor or angiotensin receptor blocker. So you want drugs that you can withdraw. So I'm not sure it's worth encouraging once a week drug. Because, you know, Thursday ko nahi diya, so Friday, we'll take it on Friday. It doesn't work like that. One drug, the aliskiren, has a 48-hour action.
Yeah.
But I'm not sure it's good idea to have a once-a-week drug. You should be able to pull out also. Drugs have side effects. You shouldn't expose to a drug which will go on working. I gave you the example of chlorthalidone.
I think pros and cons are there. Very rightly you have pointed out the cons.
Probably yes, but so do all diuretics. I'm sorry? I don't think anybody knows. There have been studies. The TOME study is probably the best that looked at erectile dysfunction, where I think chlorthalidone was the drug. At 2 years, it was worse than others, but at 4 years, it wasn't. So I don't know if people got older and didn't care as much by 4 years as they did at 2 years. But hypertension causes erectile dysfunction. So maybe if we prevented hypertension, our endothelium would be a lot healthier rather than waiting to blame the drug for it.
Some question, I think there are no questions on audience. There are some questions which I am having in front of me. To Dr. Black, when is JNC 8 guideline arriving, and is CTD going to be there in JNC 8? That's the question.
I tried to answer the question about JNC8 earlier, and I'll try to explain a little bit why it's been so late. The JNC7 study was done by 9 of us, and it took 3 months. Then the director of NHLBI, Claude L'Enfant, retired, and a new director came along who was a basic scientist. That was Betsy Nabel. So she fixed something that wasn't broken. The Joint National Committee and the Adult Treatment Panel for lipids was a very effective group. So she wanted to do something else. She wanted a comprehensive guideline that took into account all of this. So 9 people morphed into 62 people. The face-to-face meetings we had about every 4 weeks became telephone conference calls, and nothing's happened. When they started out, they identified questions to answer. 5 questions. They still haven't finished doing that. So I think it's a failed process. It's the overregulation of everything that happens. And I think the slavish worshiping of, quote, evidence-based medicine, which means trials. Trials are 6 years long, maybe 8 years. Hypertension is a lifetime problem. And to only look at trials without everything else, I think is not an appropriate thing to do. So I'm very happy that I have nothing to do with JNC8. I'll have a chance to be critical of it as soon as it comes out, and I promise you I will be.
Other question, Professor Henry, is similar to what we got in the morning at KM Hospital, is in night dippers, what will happen if you use chlorthalidone? Night dippers of blood pressure in the night time. When the blood pressure dips in the night, what will happen with chlorthalidone when you use it?
What about dippers? Okay, the question of ambulatory monitoring, which is something else that NICE recommended. We learn a lot more from ambulatory blood pressure than just what the average 24-hour blood pressure is. We learn what happens at night. We know that people whose blood pressure drops between daytime and nighttime about 15% or more have better outcomes. That's pretty condensed. People who don't, they're called dippers. People whose blood pressure drops less than that are called non-dippers. One of the problems is if you test the same person on 2 different days, they very often switch. So even one 24-hour reading doesn't necessarily classify you as a dipper or a non-dipper. It also teaches us about blood pressure variability, which some people think is an important predictor of outcomes. It talks about the blood pressure load, the number of readings you have that are elevated. All of those things you can learn from ambulatory monitoring that you don't learn from home monitoring. Home monitoring is an inexpensive and a good substitute, but it doesn't get all the information an ambulatory blood pressure monitoring study would give you. So non-dippers, in most people's experience, have a worse long-term prognosis than do dippers. But you can be an excessive dipper also, and that has a bad prognosis.
Other question is to Professor Kiplani. Can we have drug-free weekly off on Sunday from antihypertensive drugs?
It's a diuretic. It's the probably only drug that you could reduce or increase the frequency. I'm sorry, reduce the frequency. Because diuretics not only reduce the intravascular volume, but over a long period of time, the arterial tone settles down and relaxes because of the intra-arterial sodium-potassium balance, the electrolyte balance. And that effect lasts longer. So over a longer period of time, perhaps, but it's not something to encourage, because if the patient takes off for one day, starts taking liberties. And I've learned that the hard way, that if you tell a patient that, you could take one day off and take one later, more often than not he'll cheat on the drug. So once a day is ideal. 3 times a day like nifedipine is not ideal because he's going to forget. But if you're going to tell him you could take 1 holiday a week, he'll take 3-4 holidays a week. That's my understanding of it. Professor Blackwood?
Yeah, I completely agree. I think if you are doing well with a once-a-day drug, that's what it is. It should be every morning you take it, or whenever you take it, that's when you're going to remember it. There's no advantage, I think, to skipping a day. There's a lot of disadvantages. And people used to like what they call step-down therapy. And I never did like that. So if somebody's doing well, if it ain't broke, I don't want to fix it. And so if if it's working and you're tolerating it and you can afford it, fair enough. Don't stop.
Other question is, what is the first-line drug in young hypertensives? Young hypertensives, what is the first-line drug?
First-line drug in young hypertensives, that's probably, again, I would agree with what Nice said, that it ought to be a RAS blocker. They picked 55 as a distinction between young and old. I happen not to like ACE inhibitors. The cough is very common, maybe 20% here, maybe 10% in our population. And that means that you're starting something that you're going to have to stop in 1 out of 5 people. That's a complete waste of time and money. ARBs are pretty much equally good and don't have that problem. So I would favor using ARBs in a younger person.
Other question, I think probably Professor Kiplani would be best to answer. How to deal with hyponatremia and how common it is in...
I think hyponatremia is a great cause of anxiety, particularly in the hot climate that we live in. This was discussed quite a bit this morning at KM when Sir Black was addressing the issue. The important thing is to be aware of it. If you are on a diuretic, the chances are that if the dose is high, you're going to get hyponatremia and hypokalemia. Therefore, frequent estimations and frequent evaluation of the patient. This remark, of course, is limited to those who have normal renal function. In people who have GFR less than 45 or creatinine less than 1.8, the thiazide and thiazide-like drugs are not recommended because of the problem of, one, insensitivity to the drug, because the drug has to be excreted into the tubule before it works. And that's not possible once the GFR is below 45. Up to 60, excellent drugs. Below 45, below 60 and between 45, quite useful. Below 45, probably some other diuretic like furosemide or combination with metolazone. Hyponatremia would manifest clinically, but subclinical hyponatremia is also important. So I would say a frequent estimation of electrolytes, particularly in the old who tend to not eat well, skip food for no reason at all. Slight changes in sodium make them behave foolishly, drowsy, not eat, and it sets up a vicious cycle. So I think that problem does exist in higher doses.
In ambulatory, normal blood people with ambulatory who are quite mobile and eating well, generally we don't see that. Maybe Professor Siddharth would.
But you know, the important thing is that when a patient is on diuretic, you also have to enforce salt restriction. If you don't enforce salt restriction, one is that the drug won't be very effective and there will be an escape phenomenon. And secondly, other drugs will also not be effective. You are using a lisinopril with diuretic. You will find that if your diuretic is to be effective and lisinopril is to be effective, you also need to tell the patient not to eat too much salt. If he doesn't eat, if he eats salt, it's not going to be very effective. Target will be difficult to reach.
Yes. Professor Siddharth, would you like to add something?
I think that's very important to understand because in the presence of the dehydration, all the other drugs also have a different role, and hence one has to be very, very careful when a patient has dehydration. Sometimes even diarrhea can trigger problems, diarrhea, vomiting, and these things can really trigger hyponatremia. And one has to be very careful in acute conditions also, apart from the chronic subclinical conditions. One has to be aware of these conditions when we are treating patients of hypertension who are on diuretics.
Other question is, what are the benefits of vasodilatory action of chlorthalidone? Vasodilatory action of chlorthalidone. Vasodilatation.
Oh, I think as you said earlier, diuretics, thiazides anyway, and thiazide type diuretics are salt and water excretors for the first month. After that, they're vasodilators, and it's the same for all of them. So they really act as vasodilators, and that's also one of the reasons not to stop and start them, because you've got to excrete the salt and water. I want to make a comment about hyponatremia as well. That's a problem I unfortunately are seeing more and more of, not just in hot climates. That the kidney is smart. If the kidney is normal, it will get rid of a water load or retain a water load. If the kidney is not so smart, it's going to retain water. And most of the hyponatremia is due to excess water rather than not enough sodium. You've got to be aware of it. And if someone's serum sodium falls below 130, I have no options but to stop the diuretic and try to manage the blood pressure without it, which is hard to do. It's very difficult to really control somebody's blood pressure who needs a diuretic and can't take it.
I think if there are no... Dr. Sadanand Shetty, please.
So both the comment and the question actually to all the panelists and Professor Andy Black. There are two things in our... one is the evidences and one is the real world practice. Like what Dr. Gupta asked, in the real world, we are using hydrochlorothiazide. Now since chlorthalidone is available, and since all these evidences are favoring chlorthalidone, what is your recommendation? From tomorrow we should change your prescription pattern? You recommend that, people are going to write from tomorrow, first drug chlorthalidone, and then add on, maybe ARB, long-acting, maybe combination. But diuretic you are going to change from tomorrow. What is your carry-home message?
What is the carry-home message for the audience?
Should we change the prescription pattern? Since it is available now, earlier we didn't have the availability. Now we have got CTD.
Should you change? Okay. If the patient's doing well and controlled and tolerating it, I wouldn't change. But right now, I don't use hydrochlorothiazide. When I need to start a diuretic, it's always chlorthalidone. And that's been the case since SHEP, which I was part of. I wouldn't change something right now if the patient were at goal. If they weren't, then I would certainly switch to diuretics. You saw the switch study we did at Rush, where that made a difference in control. If I'm starting a new diuretic right now, I would certainly, and I wish I had the 6.25 milligrams available to me. All I have is a 25 milligram or 50 milligram, which I would never use the 50 milligram. So patients are told to get the 25 milligram and to cut it in half. You can't cut it into quarters. That's just not going to work. So 12 and a half is about the lowest I could give.
Thank you very much. I think it's already getting late. Obama develops hypertension, what would you do?
I don't like the term mild hypertension. I never heard of anybody have mild cancer. So that's why we staged it. If you're stage 1 and you're older, I would agree with that recommendation of using a diuretic as the first drug. If you're younger, I would use an ARB. For an older person, I think either one is good. For a younger person, I think it ought to be a ARB. CCBs are metabolically neutral. They've been used in all ages, and they can be. But this depends on cost, it depends on swelling, depends on a lot of things.
I think it's getting late, so I would like to request my colleague to propose a vote of thanks and close, so that we can close.
Good evening to all of you, sir. My sincere thanks to Professor Henry Black, who has given a wonderful presentation in spite of having sore throat. I sincerely thank Dr. B.K. Goyal, sir, Dr. Ashok Kriplani, sir, Dr. Siddharth Shah, sir, Dr. Ashok Sirsat, sir, Dr. Ajay Mahajan, sir, and Dr. G.P. Ratnaparki, sir, for being a part of this panel. Thank you very much, sir. And also I thank you all for coming across the different places of Mumbai suburbs and Thane city and sparing your evening. And the molecule which we discussed in length today is available as a CTD 6.25 and 12.5 milligram, and also in combination with losartan, that is CTD-L 25 and 50 milligram. So I sincerely request all of you, like what Dr. Shetty sir has said, right from tomorrow, sir, please start using CTD and CTD-L. Thank you. Please join us for